Here are two USMLE-style questions, focused on chronic transplant rejection, including the underlying pathophysiology and organ-specific manifestations. Question 1, Pathophysiology of chronic rejection. A 55-year-old man who underwent kidney transplantation 5 years ago presents with progressively worsening renal function. His creatinine level has steadily increased over the past year, and a biopsy shows interstitial fibrosis and vascular smooth muscle proliferation. There is also evidence of arteriosclerosis of the graft's blood vessels. Which of the following is the most likely cause of this patient's renal deterioration? A. Hyperacute rejection due to pre-existing antibodies. B. Acute cellular rejection mediated by CD8 plus T cells. C. Chronic rejection with CD4 plus T cell mediated response. D. Post-transplant lymphoproliferative disorder. E. Recurrent glomerulonephritis in the allograft. Correct answer, C. Chronic rejection with CD4 plus T cell mediated response. Explanation. Chronic rejection is a gradual process where CD4 plus T cells recognize donor MHC molecules on recipient APCs and secrete cytokines. This leads to vascular smooth muscle proliferation, arteriosclerosis, and interstitial fibrosis, causing progressive organ dysfunction. This is seen in conditions like chronic allograft nephropathy. Why not the others? A. Hyperacute rejection happens immediately and is associated with pre-existing antibodies, not chronic processes. B. Acute rejection occurs in weeks to months, not years, and involves a different immune mechanism, T-cell mediated. D. Post-transplant lymphoproliferative disorder involves lymphoid proliferation, not fibrosis or arteriosclerosis. E. Recurrent glomerulonephritis can affect the allograft, but this patient's biopsy shows classic signs of chronic rejection, not glomerular inflammation. Question 2. Organ-specific manifestations of chronic rejection. A 60-year-old woman with a history of liver transplantation 7 years ago presents with progressive jaundice and elevated liver enzymes. A liver biopsy reveals interstitial fibrosis, bile duct loss, and arteriosclerosis of the graft vessels. Which of the following is the most likely diagnosis? A. Chronic rejection with vanishing bile duct syndrome. B. Acute rejection with hepatocyte necrosis. C. Recurrent viral hepatitis in the allograft. D. Post-transplant lymphoproliferative disorder, PTLD. E. Hepatic infarction due to graft thrombosis. Correct answer. A. Chronic rejection with vanishing bile duct syndrome. Explanation. Vanishing bile duct syndrome is a specific manifestation of chronic liver transplant rejection, characterized by loss of bile ducts, fibrosis, and arteriosclerosis of the graft's vasculature. It is mediated by CD4 plus T cells responding to donor peptides. Why not the others? B. Acute rejection is more likely to cause hepatocyte necrosis and would not typically show arteriosclerosis or bile duct loss. C. Recurrent viral hepatitis can affect the allograft, but would present differently, with hepatocyte inflammation rather than fibrosis and arteriosclerosis. D. Post-transplant lymphoproliferative disorder, PTLD, causes lymphoproliferation, not bile duct loss or fibrosis. E. Hepatic infarction due to graft thrombosis would cause ischemic injury, but not the chronic, gradual changes seen in chronic rejection. Would you like to